You're listening to Medscape's In Discussion series on myelofibrosis, a podcast where thought leaders and clinical experts share their diverse insights and practical ideas for optimizing patient care. This series is hosted by Dr. Tania Jain. Dr. Jain is an associate professor of oncology at the Johns Hopkins University School of Medicine, where myeloproliferative neoplasms are the focus of her research. She is also the director of the Adult CAR T-cell therapy program for hematological malignancies at the Sidney Kimmel Comprehensive Cancer Center. Relevant disclosures can be found with the episode show notes on medscape.com or the Medscape app. The topics and discussions are planned, produced, and reviewed independently of advertisers. This podcast is intended only for U.S. healthcare professionals.
Hello, everyone. We're back in our Myelofibrosis for Medscape in Discussion podcast. This is our season 2, and this is our episode 5, where we'll talk about transplant outcomes in myelofibrosis and how to address relapse post-transplant. I'm Tania Jain, and today we have our very special guest, Dr. Rachel Salit, who is an associate professor at Fred Hutch Cancer Center and University of Washington School of Medicine. As a hematologist-oncologist, Dr. Salit specializes in stem cell transplant, focusing on improving outcomes for patients with myeloproliferative neoplasms. Her research has included developing clinical trials to enhance and improve transplant success, prevent graft versus host disease, and she also works on initiatives to support patients' return to work journeys post-transplant. Welcome, Dr. Salit. It's an honor to have you.
Thank you for having me today.
Wonderful. So what we want to talk today about is pre-transplant, post-transplant, and how to think about transplant. As I think we all would agree that transplant is presented differently, thought about differently to some extent, to patients by different clinicians and different people who see them in clinic. What is your approach and how do you come about telling patients in terms of the role of transplant, and how do you approach it?
The way I approach patients with myelofibrosis is sort of from two different sides. One is the scoring system criteria. So going over DIPSS, MIPSS, MIPSS 70. So that would include what is their blood counts look like, what is their molecular profile, their cytogenetics, do they have any peripheral blasts? Do we think that they're at imminent danger for transforming to leukemia or needing blood transfusions or platelet transfusions? And then the second side I look at it with them is what their life goals are and what they are hoping for in terms of longevity versus quality of life. I think we've made great strides in transplant in the last 10 years in myelofibrosis since the approval of JAK inhibitors. So I do talk with them about the role of JAK inhibitors in the pre-transplant setting, whether they've had one or not, depending on if they're having symptoms and splenomegaly and how that would affect the timing of transplant for them. But ultimately, I really find it's their choice and that patients have a very strong opinion. There are patients that have high risk disease on the scoring systems, but are having a rather good quality of life and don't want to rush into treatment or transplant. And then there's patients who may have a lower risk, but really feel like because of their younger age or their life goals that they would like to proceed with transplant in a more expedient manner. And so I really let the patient guide me. The third component that would go into it is what our donor search looks like. And I often don't know what the donor search looks like when I first meet with the patient. And so I always put the caveat, this is the conversation we're having now, but once we take a look at either sibling matches or unrelated donor options, risks and benefit criteria might change.
I feel like one of the things that challenges me is there's a lot of prediction that goes into making this transplant decision, especially the first part of what you mentioned in terms of, what is the risk to leukemia progression. And obviously, there's no perfect metric, at least, to identify what someone's transplant outcomes could be in terms of disease success in controlling or preventing relapse and obviously non-relapse mortality as well. So how do you play the prediction game? Obviously we without that crystal ball, how does this prediction metric work for you?
I mean, I think it is one of the most challenging things about myelofibrosis. And I often really empathize with patients in terms of how we consider this a somewhat elective procedure that you never want to have. I do think that it's tougher on them than in a patient with AML, where we say, this is your option and you need to have it now. So I think for me, the way I parse it out with them is trying to look at the kinetics of the disease. So when did it develop? How long has it been stable? If they do have peripheral blasts in their blood, have they been 1% over the last 2 years? Or were they 1% and then 2% and then 3%? Have their count stayed stable? Is their spleen growing? Are they having increasing symptoms? If patients have bad risk factors but stable disease, I'm less aggressive with them than if they have less nefarious risk factors, but it seems like their disease has progressed rather quickly. And I find sometimes in the younger patients, we're surprised at how fast the disease progresses compared to the older patients, especially if they even have one bad risk mutation.
I always say this. One of the major things that will follow is the trajectory of your disease, and those counts when they start to drop or those blasts when they start to appear is always that makes you think, at least stop and think about whether it is time for transplant, or at least push you to do a bone marrow biopsy in that direction to make that decision. What I want to get to, and I know you've been involved a lot in defining remission post transplant, which I think we all recognize is a huge unmet need because a lot of the disease features don't go away quickly after transplant, yet we think the transplant is doing successfully. And, different shapes and forms in which remission or disease recurrence post transplant can be thought about, and those things have evolved over the years. I want you to share with us how you got involved in this effort in unifying the concept of remission post transplant. What do you have to share with us for our teaching today from that exercise, from that experience?
I think the way I got involved in it, I guess from two sides. I mean, one, clinically, it's been for a long time really unsatisfying to share with patients post transplant that they have persistently low counts, that they have persistent fibrosis, that they may continue to have splenomegaly when we discharge them from the keto transplant service at day 100. In the meantime, the providers that we discharge them to, which are often general oncologists, are unclear about what to tell the patient. Are you in remission? How long are you going to stay in remission? And how do we test to see if you're going to continue to be in remission? And the second part came in, I worked on the Medicare CIBMTR composite study where we're looking at whether transplant benefits patients over 55. And we've been doing this for about the last 7 years. And when we met as a committee to define response to transplant, we used the newly developed IWG IMRT criteria for drug response in myelofibrosis. And we have found that that's very complicated in terms of CIBMTR reporting from the sites, that the people that are reviewing the charts and reporting whether a patient has responded to transplant are not responding in a consistent way. And so I was approached by Wael Saber from CIBMTR to try to come up with a definition of remission that when the centers reported whether the patient was in remission, persistent disease, or relapse, that it was being reported in a consistent way. So when we compared results between centers or compiled our data, we would be able to come to some conclusions about what types of conditioning regimens, what types of donors were really resulting in successful transplants. We recognized that there were many components to this disease, and that unlike patients with AML, where we say, oh, you're in CR1 going into transplant, that none of these patients could be considered in remission going into the transplant, that they went into transplant with persistent blasts and persistent fibrosis, persistent splenomegaly. And so going into the transplant, they were not in remission. And then we give them high dose therapy And when they come out, they're in a similar state. So we put together a committee of expert myelofibrosis transplanters from the US and from Europe. We really felt strongly that we wanted the CIBMTR and the EBMT to have the same criteria. So we could work on collaborative projects. And when we combined our data, we would have similar answers. And I think the strongest thing that came from that group is that the main thing that transplant can do, at least to date, that drugs can't do, is to put patients in molecular remission. We know that the driver mutations, the JAK2, CALR, and MPL, in the majority of patients is what initiated and drove their disease to happen, and that the majority of patients do clear their molecular driver mutation. We recognized that patients that clear their molecular driver mutations may have persistent low counts or persistent morphologic derangements in their bone marrow. And we thought, you know what, these would be sort of subsets of patients that we would consider in the molecular driver mutation remission category. And the second point that we discussed at length was that persistent molecular abnormalities, especially if they're decreasing, and this has been shown in papers that have looked at, oh, if there's a fivefold decrease in molecular driver and variable allele frequency, what that means, but that persistent disease was not the same as relapse. That persistent disease does clear over time, that as the CD3 chimerism increases, as people come off immune suppression, the persistent molecular disease can clear, and that we don't necessarily have to be aggressively taking off immune suppression or giving intervening therapy for that disease to clear. The relapse category should really be reserved for patients who have molecular clearance of disease and it later recurs. And that's a more concerning prognosis and one that would need to be addressed.
Yeah, I think that makes a lot of sense, right? I think of one way to think about it, especially as we're stating this to our patients, is that transplant is an intervention with a potential cure, but that disease elimination can take some time even after the donor hematopoiesis sets in. It's not something that's bringing about clinical remission per se, because the spleens can take time to improve and counts can take time to improve. But as long as the transplant has, as we call it, taken, probably defined by the hematopoiesis being donor now, that can eventually trigger or develop the graft versus leukemia, which will eliminate this so-called persistent disease. I think that's a great way to think about it. Do you have a sense, and I don't think I know the answer to this, the way CIBMTR captures relapse and the way EBMT captures relapse, so the American registry and the European registry, I think there's a difference in how the two registries capture relapse. Is that accurate?
I honestly don't know, but I would say one of the goals in this project and of the 12 stakeholders, I want to say there were 6 from CIBMTR and 6 from EBMT. One of the goals was to have a uniform definition. And I think the recent New England Journal paper by Gegelman et al. Really spearheaded the idea of this molecular remission definition. And I do think that the CIBMTR and Dr. Saber are very enthusiastic about this. And I think we can create a uniform reporting forms that will consistently report remission, persistent disease, and relapse as the 3 categories. You know, I do acknowledge there's going to be missing data, that not every center regularly captures molecular driver mutations. And I know we've talked about what role does chimerism have in this? And I do think looking at fractionated chimerism is important. Most of our European colleagues do not look at fractionated chimerism, which makes it a little more difficult for them. So there is inconsistency between what is able to be feasibly obtain data here versus there. They could get molecular data weekly if they wanted, versus us. I think every 3 months is probably the most that we're going to be able to test people's molecular driver mutations. And I think that blood counts and chimerism will still have a big role during that interim period. But I have kind of started piloting this with my patients, and I do feel like it's more satisfying for them. So the idea that I can see them at the 100-day post-transplant visit and say, you still have 2+ fibrosis, your spleen is still enlarged, and you're still needing platelet transfusions, but your JAK2 is negative. So we're considering this remission, is much more satisfying to them than looking at the data and seeing like, why did we even do this?
I totally agree. I think there is a huge impact that it could have, right? I mean, just bringing the European and the American efforts, I mean, just globally bringing the efforts together would be a huge impact in advancing science and research in this space, because I think right now we all struggle with how to interpret this awesome data that we have in the two registries, but we couldn't use them together or couldn't interpret them together or couldn't even compare them because it's not an apples to apples comparison. So I heard you mention that you're using this with your patients, and as you already alluded to, there are scenarios when the spleen may not be completely small and the fibrosis may not be completely gone or the counts may not be completely recovered. Share us some relapse intervention, or I'm not sure if relapse is the right phrase, but impending relapse or relapse interventions that you think about when you're seeing these patients who have some persistence of these disease features, whether it's cytopenias or transfusion requirements or splenomegaly or dropping chimerism or persistent molecular mutations. How do you approach, or what is sort of some approach metric that you have that you think about when you're seeing these patients in your post-transplant clinic?
I mean, I think at this point we're getting the molecular driver mutations every 3 months. So we'll get at the 3 month time point, 6 month, 9 months, 1 year. If at the 3 month time point they're negative by molecular, but they still have, persistent decreased CD3 chimerism, transfusion dependence, fibrosis, our goal is usually to start the immune suppression taper. And that's our standard for day 100, and then follow along. So we will repeat the chimerism monthly in patients as we taper the immune suppression if the chimerism isn't 100%. And then at 6 months, we sometimes get a bone marrow biopsy to see if there's anything concerning in the bone marrow. And even when we see some dysplasia in the 6 month marrows, it's disheartening, but we don't necessarily intervene on that. And as long as the mutations are, the variable allele frequency is decreasing, it's reassuring. Now, if at, day 100, the molecular mutation's negative, the CD33 chimerism is 100%, and at 6 months, it's 90%, and the mutation's back, then we consider doing a donor lymphocyte infusion. If the patient's off immune suppression and doesn't have GVHD, we can do it then. If the patient's still on immune suppression, I would say we conservatively taper the immune suppression and wait a month before giving the donor lymphocyte infusion. The only time we give therapy, like with HMA and JAK inhibitor potentially, would be if the patient had recurrent blast cells, either in the peripheral blood or the marrow, or they had recurrence of their abnormal cytogenetics.
Yeah, those can be tough scenarios when the blasts are starting to appear, or the visible to the eye features of disease are starting to appear. How often do you think about or consider a second transplant in this disease?
I would say not often. And we luckily have been, I mean, seeing somewhere only between 5 and 10% relapse. So at our center, we're still doing pretty myeloablative transplants. So the patients are getting Cytoxan busulfan with 4-day BU if they're less than 60, or they get fludarabine melphalan 140 if they're over 60. And so we have not seen a lot of relapse. For the patients who completely lose their CD34 chimerism or CD33 chimerism, then we look at second transplant. So there's some concern that a DLI in that case may cause an aplasia, that there's too high of a disease burden to debulk and give a DLI. In those cases, we'll give a second transplant.
Makes sense. All right. Well, this was phenomenal. I think thinking about transplant is a very unique and such a nuanced approach that we loved hearing your thoughts about how you think about it. And obviously, we look forward to reading about the definitions of remission post-transplant and hearing the discussions around it. I think it'll be pretty exciting when this comes out and we can all sort of talk about it and use it in our clinic, use it for protocols. I know you've already started doing it. We'll be looking forward to that. On behalf of all our audience and viewers, I'm very thankful to you for taking the time. With that, we're going to end our episode 5 on transplant outcomes in myelofibrosis, and we'll see you with the next episode.
Thanks for listening to Medscape's In Discussion Myelofibrosis podcast series with our host, Dr. Tania Jain. Be sure to look for more In Discussion episodes wherever you get your podcasts. Check out medscape.com or the Medscape app for show notes, links, and more information on myelofibrosis.